Hi, Lowell.
Hey, good afternoon or good middle day, Ron. Again,
Morning.
welcome to the second case, live case from the Washington Hospital Center. And again, we wanted to thank all the faculty and all the participants to make this meeting successful. We'll start our second case now, and I'm working with my close friend and colleague, Dr. Haider Hashem. Why don't you present the case, Haider?
Sure. Hi, everyone. Thanks for joining us again for the next hour. So this is our patient today is a 62-year-old gentleman with history of coronary disease, had PCI for a obtuse or left circ infarct in 2009, and then he had a stent in 2010 for his proximate right coronary artery that had ISR. Then he had brachytherapy to that, and then he comes back with angina 2 years ago, where he had a PCI to the mid LAD with intravascular lithotripsy facilitated PCI at that time. He postoperatively in one of his hip surgeries, he had a PE. He's also hypertensive, hyperlipidemic, and he's diabetic. He's coming in now with exertional angina, dizziness, and shortness of breath. And his stress test was inconclusive because he couldn't reach to the goal maximum heart rate. Next. So this is his earlier angiogram. You could see that the LAD had a stent. He almost has dual LAD system. The true LAD is almost myocardial in its course up until the distal portion. He has a large diagonal for which we had a stent that extended from the prox to the diag. And then next. And this is his large OM that was stented in the setting of an MI in 2009. Next. And this is his right coronary artery. So at that time, you see the ISR in the OM and ISR and probably another hazy lesion at the distal edge of the RCA stent. So I decided to do resting physiology and hyperemic physiology. Next. This is his FFR of right coronary artery using IV adenosine and a dose of 140 mics per kg. And after 2 minutes, you could see that we got a value of 0.79 using a cutoff of 0.8 as a significant defined by most trials. This is his RCA. Next. And then for the obtuse margin of that big OM, his FFR was 0.89 using the IV adenosine as well. So any thought from the panel on what to do?
Right coronary, maybe the first one to begin with.
Okay, sorry.
This is our crew. This for the second live case. So again, wanted to thank everyone here. Nelson will be joining us soon. He's still working on the patient with cardiogenic shock that we talked about early this morning. So he'll be joining us shortly.
Sure.
Cool. So I'll take back the panel again. So now we have two FFRs and a hazy lesion in the distal edge of the RCA stent.
So you're going to start with the right coronary, right?
Yes, sir.
Yeah.
So we're already up in the. Can we see Flora, please?
Show us the live and show us the images.
Yeah. So I'm using left radial approach. I know his right radial approach is quite tortuous from prior footprints from prior colleagues and interventionalists. So I elected to go left radial. We have a 7 French Judkin Wrights catheter, and I have a run-through wire down the right coronary artery extending to the PDA now.
Okay.
And we have also Dean Kyriakis and Richard Schlomfitz on the
Perfect.
panel.
This is the first shot from today.
The mid-right coronary with a high-grade disease.
And this is the REO of that.
Yeah.
Yeah, so my plan today, in almost all the cases of ISR that I'm doing in the cath lab here, I do prefer OCT as a imaging modality. I think it gives you better delineation of what are you dealing with in terms of the types of ISR that we defined in our paper with Waxman ISR classification, where we talk about the types of tissue that could grow inside a stent based on the chronicity of the lesion. And I do believe OCT does give you that delineation if you are dealing with intimal hyperplasia, if you're dealing with a fibrotic neoatherosclerosis or calcified, and so on and so forth. And I believe it gives better dimensions on under-expansion and pathology behind the stent if the ISR was led by a mechanical issue. So I'm just going to go ahead and do the OCT for you. I'm using today the OpStar, which is the recent generation OCT catheter.
My concern about OCT in this lesion is without pre-dilating, you're not going to get a great image possibly.
Yeah, true. So I'm going to go in first and see if we can generate a good picture here.
Probably you will be okay.
Yeah, it's I take your point, Dr. Schlafmitz. I think I'm a bit more encouraged by the RAO view. I think it's an eccentric plaque that's happening there that will hopefully be an oval shape on OCT. We'll see.
Yeah.
Sec.
Looks like you passed the.
Yeah, I passed it for sure.
Yeah.
So the OCT, good. You see two markers. The marker in the middle is where the lens, and that's where we're going to do the pullback.
And we like the OCT also.
Yeah, can you bring up OCT now? Here we go. We're ready.
See it?
Excellent.
Try to calibrate.
To start with.
Ron, are the images better now?
Yeah, much better. Not jerky.
Okay.
Thank you.
It's definitely nice now.
If you can see also side by side, but we should focus on the OCT now.
Yeah.
Very nice. Good pullback. So that was on 75, was it?
I did it on 75. Yeah.
Yeah, great. Very nice. Good clearance. Okay, very interesting. So it's beyond the stent, isn't it?
It's right beyond the stent. I agree with you.
Yeah.
The brachytherapy worked up to that stent, right?
Yeah.
It did.
Yeah, absolutely.
Indeed.
I have to make sure you know this is a 20 years technology now that's still the best post ISR.
Absolutely.
So I'm just gonna do my measurement here for a sec. So in all cases, what I try to do is first I will I kind of just put my marker into the lesion, move the posts inside to see my landing zones, to see what I'm going through. Obviously, in this case, because it's ISR, it will become good to just define what we're dealing with. I'm starting distally here. If you look at this spot, it's a semi-good area to land. And the reason I'm saying so, you have at least 180 degree of relatively normal architect of the artery. You could see the intima, you could see the media, you could see some adventitia here. This is right here for non-OCT users and IVUS users. On IVUS, you would see calcium here. There's no doubt, and you definitely see dropout. But the well-demarcated kidney-shaped nodule here is your calcium and OCT. And this will allow you for future technologies and modalities when you want to treat. You can measure how superficial, how deep. You can measure how thick the calcium is, and you can pick your modality. And everything comes in automatically done by the machine. Now, most of the measurements is done by the algorithm that's installed in the OCT machine. So if you have a doubt, you can verify it. Other than that, you can just try the machine and move on. You could definitely see a calcified nodule here. This is probably more calcium than what we just saw. This is almost 180 going this way. It's a deep calcified lesion. This is the tightest area. I'm getting a lumen area of 1.55 right here. There's calcified nodule here. There's calcium here. It's and I think that's why the eccentric view on angiogram is right here. If you look right, sorry. If I spin my axis, my camera, and you look down here, you almost take the lesion out because you're cutting through the longitudinal axis of the oval. If you go this way, you see that the lesion is tighter. However, I never rely on this OCT longitudinal view, the 2D. I always go by the 3D reconstruction because it's telling you there is definitely a tight lesion here, and here we go. Moving forward, there's a big nodule here, a big nodule here. Both are thick calcium. There's probably more calcium here. There's one here. There's one there.
A lot of deep ones.
A lot of deep one and thick ones. That's the the highlight, I think, of this OCT. This is right at the distal edge of the stent. So the pathology starts at the de novo and kind of creep back up to the stent. And I'm going to get through the stent now to kind of talk a little bit on ISR. This is all neoatherosclerosis as expected from a stent that was implanted 2009. You could definitely see that there's a lot of fibrous plaque that's forming. It loses the homogeneity of intimal hyperplasia. It turns into a more heterogeneous. That could tell you there is lipid, there is fibrous. As we see here, there's lipid core. There's a lot of fibrous plaque here. Moving down the stent. Same pathology. Yeah, more.
That's good. Yeah.
Yeah, and this is good. And you probably see some calcium behind the stent here, but the MLA is huge, as you could read here on 9.9 millimeters square millimeter. So I think we just need to probably work on the distal edge and behind it.
So can we just discuss then this pattern of calcium distribution? So there's clearly thick calcium. If you just move it slightly, so this really gives a nice view. So between 9 o'clock and sort of 2 o'clock here, it doesn't seem to protrude too much into the lumen. This is a thick layer of calcium in that region. But between sort of 7 o'clock and 3 o'clock, I think that's quite a protrusive nodule. Rich, I don't know what you think about the way this calcium is impinging on the lumen. Would you see this as a nodular protrusive calcium? Is this something that Shockwave could modify, or do we need some other form of debulking device?
So I don't think we know for sure if Shockwave is going to get rid of nodular calcium. I've been working on that in the last few weeks, and it fractures the calcium for sure, but it doesn't go off like CSI does.
Yeah.
CSI.
Yeah, we're not. Yeah.
So I think this is a combination, like a deep calcium that's touching the lumen that's thick, as well as nodular. It's interesting. You have over 180 degrees. I think Shockwave would be worthwhile to try, but I think any atherectomy, whether it's rotoblade or orbital atherectomy or Shockwave, would be interesting here.
Yeah, it may be that you require a combination of atherectomy with CSI and then Shockwave. So, I mean, it's a very interesting lesion. I think there is calcium extending from the distal edge of the stent. It's behind the stent, and then it seems to be sort of growing into the lumen beyond the stent.
It would be interesting to see what the Shockwave does to the nodule. I mean,
yeah,
the ability
that'd be the nice way to start.
Sure.
Yeah, let's have a look, and perhaps give quite a lot of the shocks to that region.
Yeah.
Perfect.
So very short.
So we can start with them. Oh, go ahead.
Yeah, no, I was just going to say, so just in summary, you have 180 degrees of calcium. Is that what you're saying?
Well, yes. There's different segments. There's segments with 180. There's segments with nodular. So the morphology changes through even within the short segment of this lesion. So I think there's more than one calcium distribution type here.
So for argument's sake, why couldn't we just try a balloon and see how that works?
You could?
Yeah, it's possible.
See whether this,
it's possible to do that.
And if it doesn't fully expand, you Shockwave.
Yeah. So I kind of had this probably before with you, Lowell. If I pick a 1-to-1 non-compliant balloon now, go to high pressures, I might end up with a dissection with nodular. This is the notorious nodular lesions. I would rather use a balloon when it's one side almost normal, one side is an arc of calcium. With the nodularity, all I'm going to do is I'm just going to rip apart the artery on the sides of the nodules, at least from what I see with my OCTs when I do.
If I think a nodule or nothing else, I 100% agree with you. But in this situation where you have superficial calcium on the other wall, I think you could get by with a high pressure balloon.
Also, why can't you dilate to begin with?
We'll try that. No worries.
And see what happens. Otherwise, we can go probably.
Sure.
You may actually end up disrupting the arteries quite significantly with dissection.
I actually like to be more conservative and not to.
Why don't we try a low pressure inflation with
Sure.
a shockwave, and then see what happens. And then if there's no modification, take a high pressure balloon. But I think it'd be interesting to see the mechanism, particularly with the nodular calcium, whether or not it modifies
we
it.
can dilate first, intermediate, and then if that does not work, we can go with the.
I would go with a shockwave
Shockwave.
first because I'd like to see what does a shockwave does as a standalone on the nodule.
Well, you can use the shockwave balloon without applying the energy and see what it does at low pressure.
100%. So let's get a 3.5 intravascular
Ron,
lithotripsy.
can I interject something, Ron?
Please.
You know, I do a lot of shockwave in the lower extremities. In my experience,
do
you know,
shockwave.
we do a lot of. I was everything
You were in a
before
shockwave
doing the
balloon.
shockwave, and I've noticed that if less than 270 or less than that of a quadrant of calcification, don't seem to see the clinical benefit of using the device. Although if it's 360 or 270 more, definitely shockwaves bring you know a big difference in terms of the outcome. But I'm talking about it in common femoral and SFA, not an experience in the coronary bed, you know.
So we have Dean Kyriakis. He's the PI of the CAD, CAD's trial. And you've seen probably a lot of those cases as they entered, and there were also an OCT subset. Would you say that this is a suitable case for shockwave, Dean? If you can unmute.
Ron, I don't think there's any downside to it, to be honest with you.
Well, there is, Dean. I mean, the cost is a problem.
Well, yeah.
So that's
No, I
important.
get that.
I don't want. I never think cost is important when I see a huge clinical benefit, but the
Yeah.
cost is an issue, and we're all
Yeah.
going to have this for the next 6 months or longer. So I'm just
Yeah.
trying to target best with the information
Mhm.
that we have. What would be best in this situation?
You know, Lowell, if that were me, I might have just taken the NC balloon. It might have
Okay.
been your approach
That's
too.
what I.
and
That's what I
just
said personally.
dilated.
Yeah.
Okay.
Yeah, that's what I agree.
But we can try. You know, we're going to do it. So we'll use the concept of just using the shockwave balloon at pressure and see what happens. And then, you know, I think that's a good test.
Yeah, the plan was this is a live demonstration. We are demonstrating this, but it's nice to see what's the balloon going to do without the energy first.
Yeah, Ron,
Right.
would you have done it to begin with? Just on me, I understand what you're doing right now, but are you really care by going with?
You have a lot of choices here. I think that start with the balloon is okay. CSI is okay. There's no doubt there's a lot of calcium. I do believe that you need something more than just balloon to get this
Can you flip it twice, Justin?
area, which was look like
Flip it
very
to contrast twice, please.
narrow and calcified beyond just balloon.
One important point here with the OCT is that to optimize your shockwave, several things. You want one-to-one balloon to artery size, and you can't get that from an angiogram. OCT gives you precision with that. Number two is you want to focus your 80 pulses, if you're going to be conserving dollars, where the calcium is. It's a lesion that could be long, but you want to focus it exactly where you want. And with co-registration, you can do that with OCT.
But this one, this looks like is very small, not very big area.
But you know that from OCT. You wouldn't know that from an angiogram necessarily.
So,
Yeah.
so Dr. Schlamfitz, you showed us your algorithm last week. Where this fits in the algorithm? The imaging did pass. And
This clearly fits for shockwave in that it has greater than 0.5 depth. It has greater than 270-degree arc. So it meets the criteria that balloon is not going to get a great result statistically, that you need some type of atherectomy. The fact that you can cross with the OCT without predilatation, I think you'll get the shockwave across. I think this is a perfect case for shockwave.
So for those who are not familiar with the system, maybe after you place the balloon, you'll show all the components because it was just approved in the US a month ago. We'd like to.
Can I have another run through wire or Lush?
Hey,
You might need to just take a guideliner and
Yeah.
He'll
Yeah,
do it with
Guideliner maybe help.
this
Or a
can
body
be
wire.
more problematic than you would think, very
or just
frankly.
intubate the right
Yeah.
bit more.
And that's part of why we're starting with the balloon may help.
So if you guys are looking at the fluoro, its inability to cross the proximal part of the stent, I think the compliance of the artery now is fighting rather than a obstructive lesion.
Yeah.
Look like
Was the proximal part of that stent well opposed?
Yeah,
Ron?
that was
was
greatly
it-
opposed. Yes,
Yeah, we saw it by OCT.
we did.
Yeah.
Can I have
You
a
saw
Godzilla,
it.
please?
I thought there was an edge actually, but
Yeah, start with that and you'll be able to go. Otherwise, again, the question is the balloon maybe is the easiest.
That's true. I mean, balloon would be definitely easier, but the guideline will give you a fresh de novo IVL on the lesion.
That's exactly what I'm talking about.
very often we would use the guideline in combination with the Shockwave balloon to inchworm down.
Yeah.
Using the balloon, not with the Shockwave energy, but just to deliver the guideliner, and then once you're in position, then you can use the Shockwave.
But maybe the IVL is more difficult in this particular case.
It is. It's a little bit
Just
more,
it by itself.
In the study, what I used a lot, Jonathan, was a trap liner so that I could change out for a wiggle very easily.
Yeah.
Because a wiggle guideline is really nice.
Yeah.
You have a lot to choose from today. You have the Godzilla, you have the guideliner, you have the telescope. Nelson, how do you pick the catheter of choice?
Right now, it's our bias right now, Lord. I've been picking the telescope mainly for one simple reason, Ron. It's the way it's manufactured, right? I told you it's basically woven. So when I go through, I think I did a case with you where we're like almost like 270 turn, and the catheter stayed luminal. I mean, what I mean to say, it kept the form without getting any kink on the catheter itself, and that's what reason I use that device these days. Actually, I'm looking at the OCT, Hader.
Yes, sir.
You have a ridge there. That's why it's most likely getting caught on the ridge.
So this is the distal part. So if you go to the proximal part, I think the stent was looking fine.
Yeah, there's a ridge. That's why. Yeah. That's why you're getting caught in that. It's a bulky balloon, a very good balloon, but it's just bulky.
That's why you're getting cut.
Thanks. Can you get the Shockwave ready again? I'll use it to deliver my guide extension.
Actually, Dr. Koryakis, consider that this lesion is more of like eccentric, like nodules, right, Hader?
Yes, sir.
Rather than what do you think happens when we deliver the energy of Shockwave on these nodules? The reason I asked that question is because we've been playing with this game in the SFA in the common femoral. We've noticed that if I do it on a concentric, my God, it works like magic. But when you have nodularity, especially if it's thick and big, I don't get a perfect result with it. So maybe that's a question I'm asking, because I think, Dr. Umbrich, you have on your protocol, on a guideline, is when you see nodular, maybe a best choice would be use like an orbital atherectomy in order to get to those calcifications. Just a question.
Hey, I'm going to bounce that. I appreciate that question. I'm going to bounce back to Rich Slotmitz, because Richie, you're looking at the OCT from CAD 1 through 4. We have an MOA paper that'll be out in online in the next 10 days in JACC CI on the principles of IVL, and I think you'll find it very fascinating. We have just returned to JACC CI with revision 628 patients in the clinical outcomes. This will be an abstract presented at ACC. It's the combined patient level with all adjudicated by core labs.
I have the balloon, the non-compliant balloon.
Is doing the OCT. And about 18% have nodules.
Yeah, I just need the 3.0 to deliver the
My question, Lol, I'm questioning right now. Do you want to continue with that or dilate first with the balloon and then follow again?
Just take at least a 2.0 balloon down is what we did for the trial, and just pre-dilate it nicely and then see what you get. And sometimes honestly, it's not worth all the time and effort.
That's what I'm saying.
Yeah. And
I think it's easier.
I do
it's the proximal edge here.
It's the proximal edge.
Dilate a bit and then you can go back.
True. That's what we're doing now.
Yeah.
Or another.
You'll get across if you pre-dilate. Hey, Rich,
or Heather, you can do it inching it. You know what I mean?
I'm gonna inchworm it with the balloon. Yes.
Do what you call the modern child.
Yeah.
Yeah.
Usually, if you're going to pre-dilate, just use that to drag down your telescope.
Yeah. Yes, sir.
And that's what you got to do. Yeah.
But Rich, we see nodules in 18% ballpark of all the OCTs.
Yeah, you do a combination for sure. But, I think what you're going to see with the nodules, and I've been working on a lot of nodules with IVL now since it's been released, and you don't get it shaved off. You crack it, you fracture it, but it depends on the size of the vessel. You're not going to get the stent against the wall like a perfect
It's much easier now.
Well,
The
it's
stuff
still struggling there, not that easy.
is not there. No, that's why.
And that's a non-compliant balloon, I assume.
Yes,
right?
sir.
I think you got an edge on the proximal stent.
That's the
Yeah.
that's why
Wiggle wire.
the smoothest and
I
the
would just
best.
put a wiggle wire.
Or we can get a compliant balloon and it'll
Just
go
to-
right by.
Exactly.
Yeah.
That's what I would do.
I'm gonna
Yeah,
just
okay.
raise my hand and just say a balloon at the very beginning. I want to know what we end up with.
You
We
could
are-
dilate it first.
You got, let's see, we got a telescope, we got a shockwave balloon, we got a non-compliant balloon.
And
You
that's
got
why I would not have gone with the
And he's got it now
Shockwave
though.
at the beginning.
He's got it.
You're working
Yeah.
hard.
Tiny
So
bit.
just do a gentle
Why don't you bring the telescope
inflation.
all the
Yeah,
way down?
just go up nominal.
Gentle inflation at the lesion and then pull it in.
Yeah, sometimes it is rough.
We're at 2, 4.
My question to the panel is, how good is this technique of
8.
just using a 2025 balloon to ensure that you have good dilatation of the lesion? Because I can tell you
Go
for a fact
down.
that
You want me to
we've
go
been
down?
burned so many times using this technique and say, oh yeah, the stent's going to open up. And then you put the stent and you see a nodule basically banging on your stent. So it makes me wonder about this technique of using a 2025 balloon and say, hey, it opened up very nicely.
Yeah, I see
We
the
should be
pressure.
able to deliver the stent. Just as a question to the
So
panel.
I'm now right at the lesion, I guess, with my guide extension. I'm gonna try to bring the IVL balloon now, and then we'll
Well,
we'll
do
see
you
how
want
that
to
goes.
ultrasound it now? Or what size balloon did we just use to pre-dilate?
3-0.
Do you want to ultrasound it now, or is that everyone afraid to see what the ultrasound?
No,
is?
no,
In fact, I just
I'm
don't
not
know.
about ID. It's just OCT.
If I
You're
was
here.
CT, I wouldn't be able to
Um,
inject with. I have to do a manual
Yeah,
injection. with the guide
everybody is not
extension.
happy.
Oh,
Leave it be.
everybody's not happy.
I'm happy.
Don't forget. Leave it be.
This is a part of the unknown. We just
Oh, we can ultrasound here.
I just like it. Keep it simple in the lab. that's all.
I can get an IVUS. Do you have an IVUS?
You have the IVUS catheter?
Lowell, we know what you're doing.
Don't listen to anything we're saying. PCI by committee. It doesn't work.
No, it's good. It's good
just
to have a lot of
just
options,
ignore
but
us. Ignore us.
You have the wire, please.
So what are you
Yeah,
doing?
let's see
now?
how
So
We're
I'm.
gonna try to see
I
what
have the guide
IVL is.
extension all the way down, and
Yeah.
now I'm gonna try to bring the same 3512 IVL balloon to the distal edge
should-
of that stent.
Okay,
It
Okay.
should go. It should go.
that's
let's
good.
see it.
Just have us one more step in terms of time.
You're coming.
Oh
Here you go.
Oh no.
no, push
No.
back. Yeah,
Push.
It's gonna be difficult.
yeah, it's gonna be difficult to deliver.
Yeah. So maybe
No,
given
no,
the
no.
time,
Ada, I think you
I
have to
think-
bring the guide telescope all the way down.
Yeah, I have to
That's- I
I
unsheath
think
it.
just take a non-compliant 2.5 or and then
Yeah,
take
can
it
have
all the
a,
way
uh,
down.
Can I have a 2515 non-compliant or 30 non-compliant?
or compliant to
Oh, sorry,
Or compliant. Yeah, I think
I
that's-
meant compliant.
maybe the
I meant
compliant would
compliant.
be easiest for
Yeah,
you.
yeah.
Yeah.
You need a
what size compliant do you want?
3015.
3015.
or 2.5
Or-
would be fine.
Yeah.
Exactly.
What do you got?
It'll be
30
fine.
what?
Emerge.
I mean,
Yeah,
the
emerge,
30
emerge.
non-compliant
We got it.
delivered in a second.
Compliant
Second
should be
ago.
actually, deliver the
3.0
telescope.
emerge.
So the
and you'll be
telescope is
perfectly
easier to
fine.
use the compliant device.
So Richard, between orbital to rota, what would be?
Can we give
what
1000 of IV heparin, please?
I mean, when I have nodular lesions, I usually go to CSI.
1000.
Huh?
I have many examples of just giving it a haircut and shaving.
Oh,
So, Rich, have you been using CSI?
Oh, we lost the voice.
Yeah. We're off audio.
we lost the audio.
We don't have audio. Okay.
Au revoir. Thank you.
Otherwise, just bring the telescope all the way down distal.
Yes, I will. Go up here, please.
Ready?
Yeah. Nominal.
I'm
Okay.
going up to, what would you like?
Right, 10.
10? Here's
Yes,
10.
please.
Do you have your audio?
Higher.
Yeah, we're good.
It's yeah. We just cut the audio back, Ron.
So this is a 2.5
No,
3-0.
they use a 3.0 balloon right now, Ron. 3.0 by
No,
It's a
15.
3.0
non-compliant.
Back
Good
at
then.
all?
Compliant.
and
No.
dilate distally as well.
Yes, we will.
The plan is just to bring the support
get it.
catheter all the way down beyond the lesion.
Yeah.
Yeah, dilate as fast as
Push the
you
balloon
can.
out now.
Go up here, please.
Dilate.
Yeah, go up.
And
Okay.
don't
Okay.
forget that we have to finish it before you.
So this is a
That's
nice technique
beautiful,
to
right there,
guideliner further down the vessel
Okay, down.
right there.
and pull.
Yeah.
And you need a wire.
It's probably not going to go through, but it may just stay at that nodule.
No, I
You
think
should
So
get the
I think I'm hitting
Hey.
the nodule now because I'm right at the lesion
Yeah,
with the
you're-
guide the
you're on
extension.
the-
Pedro, I
on the
think
nodule.
you have to bring it further down if you want to.
Yeah, I think we
Go
let
up
you
again,
do
please.
it.
What you
But
need?
Go up again.
yeah, we should leave it what
And
you
so
want to
you're-
do. But I believe that to
You're
dilate
dilating the
further
whole
and
distal
then
vessel.
go back with
No.
IVL will be a good
And down.
way.
Yeah. Yeah,
And
the
as it
proximal
goes
bit
down,
hasn't
the
fully
IVL
inflated.
The guideliner advanced forward.
I think you're stuck on the nodule here.
Yeah, I'm stuck on the nodule. I don't think it will move
Yeah.
forward anymore.
I think the shockwave will go now. So
We'll try it.
We'll try.
Yeah, let's try with the IVL again.
So
Yeah, it is definitely.
I mean, my used 3.0 semi-compliant balloon is flying through the lesion or the guideliner, got the guide extension very freely now.
Yes, and you will be fine.
with the discussion about eccentric, nodular, concentric.
Can I have the shockwave again?
The experience is that with the
Yeah, see that?
Yeah.
As Hader was describing with the eccentric in the peripherals, that you don't seem to see much modification. Now, some of the work that's been done is by Margaret McIntaggart in Glasgow, looking at eccentric calcification, is that where you get in the concentric lesions, where you get reverberation of the shock wave, and that you get a sort of double effect from each shock. With eccentric, you only get, there's only really one, there's no reflection from the other side of the vessel. So you actually have to apply more shock waves to the eccentric lesions. And I think this will apply to this nodular lesion. So the point I'm making is that you should apply as much energy as you can. I would use up all of the balloon's energy, all the 80 shocks to this.
Yeah,
to
we
this
all
region.
agree with you.
Well, I have one.
Yeah.
Thanks.
Okay.
Jonathan, I think is correct.
What about the concept of kissing shockwave balloons?
Right, you pass now the
I
lesion.
passed through 100%.
You pass the lesion.
So I'm gonna back my guide.
You see why you can advance it?
Yes,
That's
sir.
the reason.
Very nice demonstration.
That's exactly the point. That's why we said about the pre-dilatation would be the best, and then move with the shockwave.
So, Dean, can you remember the exact number of pre-dilatation? What was the percentage of pre-dilatation?
47%.
47.
Okay. Less than half were pre-dilated, and 60+% were radial use in our trial.
Yeah, yeah.
And
that quite a lot of guideline
to go back a little, right?
Okay.
We were at the distal edge of the stent. I'll bring back a little.
I don't think you need to push it. I don't. You need to push it anymore.
No, I think we're gonna pull back a little more, just a tiny bit. I think.
Come back a bit further, because it's right on the edge of the stent. Put the middle of the balloon.
Don't go back too much, because
no,
you're going
I don't want to lose it.
There we are. That's
fine.
That's good.
Again.
Yeah,
I think we're in a good shape here.
Good.
Okay, let's go up.
Perfect.
So now we're gonna follow up the SRAP-CAT3 algorithm and protocol. I'm going up to 4 atmosphere.
Right.
This is my 4 atmospheres here.
Yes.
Can I show it to everyone?
Yeah, we see it.
You see it? There's definitely a divot there.
Well.
And we're going to deploy the first 10. Go ahead.
So can you, so the console, we see the
If
numbers.
you can show the EKG, that would be great.
Yeah,
can
so
see
we
it from
definitely
here.
see the spikes here on the.
Yeah,
can we see
they want the
hemodynamics?
hemodynamics.
And now we're done with 10 seconds of deployment. I'm going to go up to 6.
Exactly. And
I
you
think
can
this is
go
a
all the
bubble
way to
that wasn't there.
It's a
So-
cavitation
Yeah.
bubble, yeah.
But
And then we're down.
do you think there's an indent though in the middle of the
There was an
balloon?
indent for
There-
sure.
Yeah.
It
Yeah,
will be.
but-
Yeah, it will be.
Yeah, we'll see if that goes away.
Yeah,
So you
that's
can
it.
see,
Up to
yeah.
it goes up to.
But
80.
that was at 6 atmospheres, the indent, right?
The indent was at 4.
Yeah.
So I'm going again now with the 4 atmospheres.
up to all the way up to 80.
This is 4.
Despite all the equipment, the STs come down pretty nicely at the end of
Yeah.
that. Equipment
Yeah,
stuck
you'll
in
see
the
it.
vessel.
But-
Small indentation.
Yeah, which
Here,
I thought there was at 6 actually also.
Yeah, it's
I'm
there.
gonna
You'll see
show
in a
On
second.
3 o'clock position.
So we're doing the 10. Now you see the spikes, the telemetry
Yeah.
artifact there. And now I'm going to go up to 6. And then we'll show you how that looks on Cinegram. Here we
You're
go.
now-
It's there.
There's an
there.
indent, yeah.
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 Indenting, but it's making better. It's
Let's
getting better.
Now, one thing you can
Yeah,
do is make some
I'm with you.
small adjustments to the
Give
balloon
me-
position, either
Yeah.
slightly further forward or slightly further back, so that you concentrate the energy next to each emitter. So
Yeah.
that
I personally believe it's more distal
yeah,
before you get a problem.
So you're voting I move distal a little.
Yes,
I would-
because I don't want to
You
get
move it
stuck.
to the distal, but
and
I-
then come
was
back
only
more into the.
On OCT, it was only 5 millimeter from
Yeah,
the edge of
but-
the stent.
Yeah, but
Yeah,
it looks like it is more a little bit distal.
it was a
I
short
believe.
segment, Maurice.
well, you could go a bit distal and then come a bit proximal. I think
That's
just
exactly what I'm asking.
moving the energy up and down this segment.
Yes,
I'm going a bit more distal now.
Okay.
4, please.
Jonathan, you are correct.
And again, this is a 3.5 balloon.
Yes, sir.
Yes, it's making good progress.
So this is
Why do
your
you go
4
to-
atmospheres.
Jonathan,
Okay,
why do you go to
deploy.
6 at the end?
What's that?
Why do you go to 6 atmospheres at the end?
I've stopped. I get too bored. Sorry.
I don't understand the physiology.
It's too long.
People
Just do
ask me,
4.
I can't figure it out.
See, as long as you can. Yeah.
Yeah. Sorry, that's not
There
the
we go. I think the
official
indentation
thing
is
to
better
say.
now.
Oh, look, that looks much better.
Let me
Yeah.
Look at the
Right.
difference, though.
Down.
Don't you think there is a little
Yeah,
bit different?
yeah, definitely.
Yeah,
now.
100%.
Yeah, it is.
Yeah, there's a difference.
Yeah.
Definitely looks better.
How
Yeah,
much?
that's where
How
we
many
are.
shocks have we got left now?
So I have half a catheter left. I have 4,
Okay, yeah.
4 more
giving them-
treatments.
I'm
Give
Do
them
as
more-
much as you can.
We have 50.
Yeah. Come
Oh,
a
we
bit
use
more
only 3?
proximal.
Yep.
Oh,
You don't be. You don't.
You ready to do it again?
yeah. Go ahead.
Yes.
There we are.
Don't be-
So are
don't
you
be-
saying that we don't really need to go to 6 anymore, or just?
Well, sorry. Yeah, officially. Yeah,
Okay.
that was the protocol.
Yeah, I got it.
Yeah.
Officially, we have to go
Right.
up.
I mean, I just think people will get a little, get a bit
But I-
impatient,
Well,
especially
don't
if you're
they
giving all
folks-
the shocks.
That's an
6 is
interventional
nominal.
cardiologist. That's what the problem is.
Go to 6.
But I think for Shockwave, the key thing is for the balloon to be basically touching the wall of the vessel.
You have to be patient.
Absolutely.
And actually,
Down.
in the prefer, I even go 1.1 to 1. But going on 2 to 4 atmospheres
That's
at the
good
most.
so
I don't
far.
even go to 6 or the 8 that they talk about. So just low pressure. And I think the key thing is to have contact of the balloon to the wall of the vessel to deliver the shock wave. I think that's the most important,
Absolutely.
of what we're
That's
trying to do.
Jonathan, don't you think giving it as long as you can is best? I think the
Oh, well,
time.
you're only applying the shock waves for that 10 seconds whilst your finger's on the button.
Right.
The other 6 atmospheres, there's no shock waves being delivered then.
And in the
That's just-
study, you
go
did
ahead.
4 atmospheres, went to 6
Mhm.
once you were done with your shock. It doesn't make
Yeah,
sense.
once you're done with the shock, yeah. But that's when we were being, extremely careful when we first started. But I actually think we're probably going to just move
Go
to
ahead,
just
deploy.
giving it
Oh.
I
I
believe
think
it's
it's
gonna
gone.
be.
It's gone.
low pressure.
Indentation is gone.
It's gone.
Yeah,
So
and
sure.
we
we have
will
to do an
see. We will
OCT
see
now.
this time.
Yeah. We'll repeat OCT now after we deploy it.
Yeah, I think that's the difference.
6.
You will see it right now.
6 again.
Yeah, you utilize
Down.
all the catheters, so that's would give you the
No.
max. effect.
6 is the nominal pressure for the balloon. That's why. You get it.
So a nice OCT run, if you can do it on 54,
Yes, sir. I will do that.
that would be great.
Can we? Yes, yes,
Yeah,
sir.
you're
Could
ready
you
to
do
go,
it
right?
on the
It'll
H?
show you directly.
Yeah. It would also be interesting to look at the proximal edge of the stent as well, because why there was difficulty in crossing. I think there is a ridge there as well.
Yeah, it was.
Yeah. So we see if these nodules disappear.
You see it now?
No,
No,
we're
not
gonna get
yet.
the OCT.
I'm looking at the old
please?
scan.
Now look at it.
See if you can get the lenses aligned, so we've got the same.
Yes, sir.
But look at it though.
For the distal segment.
Lowell, you can see the difference. I think. This is
I
almost,
agree completely.
Yeah, we have to agree.
Show us the OCT again.
Can we have the OCT on the images, please, on the live stream?
So just for the OCT operator, is that Hader who's doing that?
Yes, sir.
Yeah. So could you just move the blue marker just for the distal on the previous one, just to get what the MSA was, or the MLA was for the previous one?
Oh, so that's okay. Sorry, that was Nelson handling the OCT.
No. Have you done it? No, we don't.
Yeah, I'll do it again.
We're gonna do a run now.
I'll do it right now.
We didn't. I don't think we did it.
Yeah, no, we'll do it.
That was the old run.
So just move your distal and proximal markers just either side of the lesion,
We'll do.
and then just tell us what the MLA
Can you move
is.
here?
Because I think the MLA was at the region of the nodule. Or the
Okay.
multiple nodules.
Just show the live flow just for a second
Can
there.
you change the pull back type to
So you can
high
see
res.
the catheter is past all of it now.
Maybe you can
Now all of a sudden you're able.
Which one you want?
the pull back
Yeah.
underneath it?
And now go
hold on,
ahead
yes.
back to the
Yeah.
OCT,
Pull
please.
back to high res.
res? Okay.
High res, please. Good.
Just
So now
remember
I'm
you
going to
can
go on
use-
high res.
You can use your guideline if you want to make sure you got really good opacification.
Yeah, I think we're
just
doing
if
good.
you- Yeah.
Going
Let's see
live.
the measurement now.
Auto calibrate. Just make sure I have no contrast here. Looking good.
I don't see angio co-registration on your screen.
You know,
They don't have
Ron,
We don't
being
have it
installed
yet.
next week.
They're installing next week.
you know,
That's a game changer.
uh,
The 3 mm. Yeah, starting with the 3 millimeter balloon, moving up with the Shockwave is exactly what's going to happen.
yeah.
Looking good so far.
Kind of
You
slow
know,
down.
Wow, this is the spot.
Look at that.
So I see the crack there.
Yep.
Yep, you saw that.
Yeah.
I'll bring it back there. You
So
had it in the same
just-
position, right?
Yes, sir.
Oh my goodness! So look
went
at
to
that
the
difference in the MLA. So can you put the markers either side of
We
the
will.
Yes.
lesion, and then
Yeah, you
show us?
see the difference, huh?
You want me to do it? No, nothing.
Yeah,
Jonathan,
You
do
can
you
do it.
agree?
Okay.
This is like a perfect.
Yeah, this is. I'm a little surprised it's as good as this. I mean, really,
That's how
very
we thought.
impressive.
Dilating
So,
first with the balloon and then moving forward.
Just
Yeah.
move
Yeah.
the
This is it.
the blue. Just take the blue proximal marker.
Okay,
on
go.
the-
Let me get this for you. Here we go. So I think I think I can probably land somewhere here.
Uh-huh.
Does
Yeah.
Does everyone agree?
Yeah,
Yes, sir.
maybe a
Okay.
bit distal. Yeah.
A
You're
bit distal
fine.
right there.
Do it whatever you think.
Yes,
Nice-
perfect. And I will. I'm gonna bring this in.
Perfect. That's enough.
I'll probably land somewhere
That's enough.
here.
Yes.
That's a good
yes.
spot.
Yeah.
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 So I'm. And then I think
So-
the lesion was right. So guys, you remember this nodule that I showed earlier? There's a
Yeah,
crack
zoom
right
back.
next to it, and
Yeah.
that was a bit more distal to the lesion. And then this was the 180 there. There's a small intimal dissection there, expected. And then I think this was our lesion that no more exists. And I went from 1.5 to 4.9 already.
Why didn't you just go back to the previous pictures and just show us that view on OCT, and just to compare, just so we have that in our mind's eye.
Sure.
No,
So
it's
remember,
really-
this is the nodule,
Yeah.
Before and
And-
after.
and then this is it.
Give us
Yeah,
the
we can
MSA
see
in
it.
that region.
Yeah.
Give us, just put the markers either side of that.
So 1.75 or even less on this. This was 1.58.
Just put the blue markers either side if you would. Just
Sure.
take the.
It's
Sorry to
kind of
be-
because it's fine. It's identifying the old stent.
Yes.
Yeah. So probably here I was thinking of at least 20 a 20 length stent.
The longest you can, though.
Yeah, the longest I can. I agree.
Don't make sure you don't miss it.
Yeah,
just accept that. So you've gone from 1.6 millimeters squared. I think the MLA I saw was about 3.79, 3.8. So
yeah, I'm gonna get you here.
At that region of very nodular calcium, that there's been substantial. I mean, it's a significant modification.
Yes.
Very.
Look at this.
Looking
Look
good.
at this one.
Yeah.
This is the one.
Yeah.
The other important
this is the lesion.
The crack there.
This is the exact lesion. The two big nodules here and there, and I'm getting a lumen area of 4.4.
Beautiful.
Yeah.
Well.
The other important point you have to bring up here is that perforation, abrupt closure, no reflow, 0 with this technology. In the pool analysis of 628 cases in our trial. You're not going to see that with the other technologies you thought you were going to use at the start of it.
Yeah.
Give me 320 plus.
So
make sure you do long enough.
Yeah,
I will do long enough, Dr. Morse. I'm with you.
Yes, sir.
In this situation, I think we can really be tempted to then go to perfect the result with a high pressure balloon.
ACT coming up.
I would really warn against it, and that's where I've run into problems having used Shockwave. There has been no perforation, and then with the stent implantation, no perforation. But when you go then with a high pressure balloon and there's nodular calcium, you push it through the wall.
I agree totally with you.
If you can get if you've changed the compliance here, you can inflate a stent with full expansion at nominal pressure, and I think you'll get a very satisfactory result.
Some nitro, please.
This is very important. I totally agree with you, because this is what happens sometimes for us.
Yeah, perfection can be the enemy of good.
Exactly. Exactly.
So, do you think we need another balloon now?
No.
No,
I think
no. Stent.
You've changed the vessel compliance with the Shockwave at low pressure. So you've got 4 atmospheres, 6 atmospheres.
Yeah, if we need a balloon, we can do it post the same way.
Afterwards, yes. Afterwards is okay, but
I would put the stent in.
100 IC nitro.
And then do an OCT, and if the areas are good, the stent is opposed, then nothing more needs to be done.
So if you can show us angio, we'll see what you're doing now.
Yes. So I'm just waiting for the stent to arrive, and then the stent is here.
Go to live fluoro, please.
And show us one angio of this post.
Yeah, sure. So this was the OCT run. So that's why I kind of save on contrast when I do OCT. Yeah. It's one-stop shopping. So this is your angio, and you could definitely see that the lesion is almost gone on angiography, at least in this view, which was the view that demonstrated the tightest area. Remember, your RAO was a bit better, but the LAO was bad. You got it?
You also see the ridge and the rigidity in the proximal segment.
Yeah, let's see how that goes.
Yeah.
We're going in now with the stent.
How long are you going to stent? How long?
I have a 22.
22.
And which stent is that?
I'm using a Resolute Onyx.
I see. Okay.
On the table.
So the Onyx 22.
Yeah, I think we will need to
guideliner in.
Yeah. I got one.
Yeah, take your take the guideliner back down.
Be careful not to push it too much. I'll try to get the guideline regular.
Yeah,
balloon.
No, sure. Can I have a regular balloon, please? This is a 22.
Last week we want to strip the stent over the.
Yeah, no, I'm with you. Can I have a balloon,
it's just
please?
It's just the rigidity. There's you haven't changed the compliance in that segment at all. So you're still
yes,
very rigid.
So Ron, just a question to the panel, right? So for people watching this live case today, so the question would be, when is basically, I think Dr. Robin has a very good
have the balloon, please.
Give
me a 3 or 15 compliance.
What is the role of doing lesion modification, either using rotational atherectomy or orbital atherectomy, if IVL does a very good job in modifying the lesion and ensuring good, basically, vessel wall preparation for stenting?
Yeah, so
right now it's called.
We need to learn that together. We have now all the 3 modalities. I agree from Dean perspective, the best safety profile you will find in IVL. Efficacy-wise, we'll have to see which one. And also it's a question of comfort with the technology.
Okay.
A lot of CSI like Dr. Schlomfitz will tell you that he's very comfortable with that. And those who are doing a lot of rotational atherectomy like Maurice will say that would be my first choice. And those who have not done many of those before, I think that they were leaning more in IVL first. But again, what is better? We're not going to have soon any head-to-head trials right now to compare and contrast. But I'm sure those trials will come, and we'll have to play by the data.
It is
sure
what it
it's-
is, correct. You are
Sure.
correct.
I'm sure it's going to be that there's a combination. I think it's the algorithmic approach that will help
Wire,
here.
please.
We've got a good
Wire.
range of tools, and I think they will fit into algorithmic thinking. I think if we inform that with intravascular imaging, I think we'll be more precise in our decision making. And I think a simple strategy is that if you can cross and there's heavy calcium burden, then Shockwave is a good first thing to use.
So I'll tell you what, we are a little bit again behind
Okay.
time. I know you started late.
Go up, please.
My suggestion is
We have 1 more minute to see
for
it
how you
because
the
it's going to be
guideline.
fine.
As you'll do it, you'll show it to us in 15 minutes.
Sure.
We're going to go to a power break now, and then you'll show us also the imaging. And
down.
right after the power break, we're going to have a 1 hour IVL symposia. So that would be a
Okay,
nice way
please.
to space
Yeah.
and to tell us what you find.
Yeah, sure.
So if that's with you, I'm going to move now to the power break. We're going to move back to the cath lab at MedStar Washington Hospital Center. Hey there, Lowell. Heather, you want to summarize the case?
Yeah. So we're all done here. I'm going to play the angio for everyone to see.
Look at this.
Wow.
Fantastic.
Yeah, I'm going to let that play while I get my OCT back up for you to, we will review the expansion data and all things that we had. So can I have OCT on the monitor now, please?
Hey, look at that.
Yeah, so all I
This is
care
great
about is the
presentation.
distal edges. This edge of the stent, there's no dissection. I move quickly to the other, which landed in the old ISR. There's nothing here. And then our lesion was somewhere right there, probably.
Yeah. You can see
Because
you can
this
see
is
the
the nodule.
cracks.
Exactly, this is the
Beautiful.
nodule. And then, so probably our lesion was here. I got an MSA of 7.27 throughout. The algorithm in the computer already told us that's 92% expanded on the distal half of the stent, and it's 97% expanded on the proximal. I think we did what we planned to do. He's feeling great.
The measurement with the IVL was perfectly fine.
Yeah.
We showed
Really good.
exactly what you wanted.
Exactly.
Great result. Great result.
I think you actually
well.
see cracks in the nodule behind the stents here. I think if we look, I mean, it's what a great result.
Yeah, it's good. Came out really well.
Certainly, yeah,
This is the presentation.
Thank you. Appreciate it. Thanks.
Well done.
Thank you.
absolutely
Anything else
brilliant.
you want to add?
No, I think it's all good. Now he has 2 shockwaves. It was part of the trial, and now he has the RCA commercially. So he's doing great.
Very good.
Thank
Very
you.
good,
Thank you.
I see Justin. I see
Justin is
other.
here. We're all done wrapping up here.
All the
Congratulations to all.
Itzig, I mean, you had a terrific show today. We're
Thanks.
going to come back from the MedStar Washington Hospital Center in the last week of CRT. That's going to be